Today I am going to discuss about the USMLE Step 2 CK Hematology. It will be part 8 and the topics will be vitamin B12 deficiency. We call it also cobalamin. And how we can develop the vitamin B12 deficiency. It could be malnutrition, like lack of oral intake of vitamin B12, like example, like someone is strict vegetarian. Vitamin B12 we can found in the fish, meat. This kind of food source is the source for the vitamin B12, and but if someone is a strict vegetarian sorry, he could have vitamin B12 deficiency, or person could have absorption at the GI tract, or person have intrinsic factor deficiency. This can cause vitamin B12 deficiency. So let's talk about how the normal people absorb the vitamin B12. Someone eat meat, fish, and this will be digested by the pancreatic enzyme that will separate the intrinsic factor, and it will separate the vitamin B12. So, and it need intrinsic factor to absorb it in the terminal ileum. So where intrinsic factor is produced? It produced in the stomach, in the parietal cell. We know that parietal cell secrete the S plus hydrogen, and then after pancreatic enzyme release the vitamin B12 from the food, then intrinsic factor will bind with it, then it will go in the terminal ileum and it will be absorbed. So is any three of these have a problem, we can develop vitamin B12 deficiency. What is this? Malnutrition. If person is not taking enough vitamin B12 orally, he has a problem in intrinsic factor, and he has a problem in terminal ileum, and all this can give someone vitamin B12 deficiency. So how we can develop intrinsic factor deficiency? Again, if someone have gastrectomy, his stomach was taken away, or he has a resection of the terminal ileum, or antibody was produced against the intrinsic factor or parietal cell. We know that parietal cell produce the intrinsic factor, so antibody is producing against intrinsic factor or parietal cell. We can develop vitamin B12 deficiency, and also in old age. So when vitamin B12 is low, what happens? Patient can develop variable symptom like pernicious anemia. What is pernicious anemia? When person develop antibody against intrinsic factor or parietal cell, and patient has low vitamin B12, then we call he has pernicious anemia. Not malnutrition, not terminal ileum deficiency causing. Those will give the vitamin B12 deficiency, but we will not call it as a pernicious anemia. And When vitamin B12 deficiency or folic acid deficiency, we can have megaloblastic anemia. In this case, blood cell will be macrocytic, big cell, greater than 100. And not all patients who has vitamin B12 deficiency can develop neurological problem, because we know that vitamin B12 deficiency can cause sideroblastic like macrocytic anemia, and the also neurological problem such as subacute combined degeneration of the spinal cord due to the defect in myelin synthesis. So you need vitamin B12 to synthesize the myelin. Without the synthesis of the myelin, we can develop subacute combined degeneration of the spinal cord in the posterior column of the spinal cord. And vitamin B12 deficiency can cause variable neurological symptoms like autonomic nervous system abnormality. For example, patient can have sympathetic nervous system, parasympathetic nervous system abnormality. If patient have neurological problem, patient can have gait ataxia. What is gait ataxia? Patient would have problem in maintain the balance, like difficult to walk, and he could have hyperreflexia. His cranial nerve would have problem, cranial nerve neuropathy. He could have peripheral neuropathy, like say motor weakness, sensory abnormality. Patient can complain he has tingling, numbness, and he could have positional vibratory abnormality due to posterior column of the spinal cord abnormality. He could have psychiatric problem. He could have memory loss, weight loss, constipation, even diarrhea, decreased appetite, bladder dysfunction, urinary bladder dysfunction, sexual dysfunction, and bowel dysfunction. We already talked. He could have constipation and diarrhea. Patient can complain he has abdominal pain. He could have stomatitis, what is like the inflammation in the mouth, glossitis, inflammation in the tongue also can happen. So who is in more risk to develop pernicious anemia? Vitamin B12 deficiency then cause the pernicious anemia. Someone has autoimmune disease, for example, he has vitiligo, so he has a problem in pigmentation in the skin, hypothyroidism due to the autoimmune disease. And if this person have one autoimmune disease, he has more probability to develop another autoimmune disease. So if someone has history like that, vitiligo, hypothyroidism, he can have develop autoimmune disease, like develop antibody agonist, intrinsic factor or parietal cell, and he can develop pernicious anemia. If a patient has pernicious anemia and does not have severe anemia, this patient could develop anemia when he becomes vegetarian. What we are talking about, someone probably have developed antibody against intrinsic factor or parietal cell, but he is not showing any symptom. His vitamin B12 is still in normal range, but when he will stop taking enough vitamin B12 orally, or he has dissection of the terminal ileum, this person can develop quickly vitamin B12 deficiency and also pernicious anemia. Usually we know that normal people have storage of the vitamin B12 for 5 years, but for this person, before when someone take fully oral take of vitamin B12, he's not taking enough vitamin B12 orally, he can develop pernicious anemia before 5 years, within a short period of time. So vitamin B12 deficiency cause impaired synthesis of the DNA, that can cause impaired synthesis of the myelin, that can cause the demyelination of the posterior column of the spinal cord. So vitamin B12 deficiency can cause neurological problem or hematological problem, or can cause the both. And it's not necessary that vitamin B12 deficiency he will develop all of this. No, probably he can develop 1 or 2. This means anemia or neurological symptom or both. So it is not necessary that vitamin B12 deficiency would cause both problem at the same time. So like all anemic symptom, vitamin B12 deficiency will also show the symptoms of the anemia. So anemia, symptom of the anemia does not give us any clue what is the causing of the anemia, because all anemic symptoms show the almost same symptom, except every individual anemic disease has some individual thing. For example, vitamin B12 deficiency also can cause the neurological symptom. So what we will find if we do the physical exam, and we know person, when we see person has intrinsic factor deficiency due to antibody against the intrinsic factor or antibody against parietal cell, we label him, he has pernicious anemia. So if we do the physical examination of the pernicious anemia, what we will see? We will see, look at his skin color. He could has a skin color will be look like a lemon. It will be look like and he will have a paler skin color. His vital sign could be normal, and we already talked that anemic patient could have flow murmur. So if we do the carotid pulse, he could be, if we try to feel the carotid pulse, it could be hyperdynamic, and his skin will be pale, his palmar crease will be look like a pale, and his conjunctiva will have pale in color. And for neurological problem, he could have weakness in all 4 extremity, and he may lose the sensation of the extremity, and the legs could be also affected. Glossitis, if you look at the tongue, his mouth could be inflammatory, his tongue would be smooth and shiny. And what would be the lab test? As we already talked before, we are suspecting person has anemia because he look pale and he has all the symptom of the anemia. He become tired very quickly, all of these, and we do the hemoglobin hematocrit value and it come below the normal. Then because we give the mean corpuscular volume, reticulocyte, it come below the normal. Then when we see the mean corpuscular volume is over 100 and reticulocyte is low, we are thinking he has macrocytic anemia. When anytime we will find a macrocytic anemia, next step is the peripheral test of the blood and see if he have hypersegmented neutrophil. And this guy with macrocytic anemia, he could have mean corpuscular hemoglobin could be increased. His mean corpuscular hemoglobin concentration could be normal, and he has anemia. Definitely his hemoglobin and hematocrit will be low. So after we found hemoglobin hematocrit is low, we do the mean corpuscular volume and reticulocyte, both come mean corpuscular volume greater than 100 and reticulocyte is below the normal. Then the next step we will do the peripheral blood smear test, and we will find that if we find that he has a neutrophil we will look at the neutrophil and he has a hypersegmented neutrophil. This means he has a more than 4 lobe, and then we will call it hypersegmented polymorphonuclear neutrophil. So when person has hypersegmented neutrophil, we call it his person has megaloblastic anemia. Who can have megaloblastic anemia? Anyone has a deficiency of the vitamin B12 and folic acid. This person give megaloblastic anemia. He have hypersegmented neutrophil. His neutrophil has more than 4 lobe. Also, if a person is taking anti-metabolite medication, what is the anti-metabolite medication? For example, methotrexate, fluorouracil, markaptopurine, hydroxyurea. This medication also can give the hypersegmented neutrophil, because this medication work to prevent the synthesis of DNA. And vitamin B12 deficiency also can impair the DNA synthesis. So if we look the peripheral smear, what will be the shape of the macrocyte cell due to the vitamin B12 deficiency? It will be look like oval macrocytosis due to vitamin B12 deficiency. We call it macroovalocyte, oval macrocyte. And he could have anisocytosis, folliculocytosis, polychromatophilia, basophilic stapling, and all of this folic acid deficiency can have all of this, and reticulocyte count will be low. We talked it before. And if we do the CBC, he could have pancytopenia. Like say polycythemia vera, we have all cell will be increased, red blood cell, white blood cell, platelet all increase in polycythemia vera. In vitamin B12 deficiency, we have pancytopenia. He have decreased reticulocyte, decreased red blood cell, white blood cell, and we already talked that if we have increased segmental neutrophil, and he will decrease band. So production of the neutrophil will be low, but his lymphocyte monocyte could be normal. And he has a macrocyte someone has a macrocyte due to vitamin B12 deficiency. He is breaking down the red blood cell. So when breaking down the red blood cell, his lactate dehydrogenase will be increased. His indirect bilirubin will be increased, and he is breaking down the red blood cell, and it is releasing the iron, so his serum iron could be high. What usually we don't need to do the bone marrow biopsy in vitamin B12 deficiency, but if we do bone marrow biopsy, what we will see in the biopsy? Person has hypercellular in the bone marrow, but the problem is blood cell is breaking down, so it cannot come to the serum. Also called megaloblastic hyperplasia. When hypercellular in the bone marrow, we call it megaloblastic hyperplasia. So let's talk about person came, he has anemia, you do the hemoglobin hematocrit, it comes below normal, you make sure it give you hints that he has anemia, then you do the test for corpuscular volume, reticulocyte in corpuscular volume came over 100, reticulocyte count low, below the normal, and then next test we will do the peripheral smear and look for to present any hypersegmented neutrophil. If hypersegmented neutrophil is present, then next test we will do the test for vitamin B12 and folic acid. And if we found vitamin B12 is normal, folic acid below the normal, and folic acid is normal, next test we will do the look for antibody against the intrinsic factor or the parietal cell. If we found there is a presence of the intrinsic factor or parietal cell, it give us a guarantee that person is developing pernicious anemia, because the antibody is destroying the parietal cell or intrinsic factor that is causing person to absorb the vitamin B12, and that is causing him to give him pernicious anemia. And if we do the test for antibody against intrinsic factor or parietal cell, and we found that there is no presence of the antibody against intrinsic factor and parietal cell, so antibody is absent here against intrinsic factor and parietal cell. The next test we will do the sealing test. So before come to do the sealing test, we have to go all of this to do the sealing test. So as we talked before, the pancreatic enzyme free the vitamin B12 from the protein, from the food. And so pancreatic enzyme is also necessary to absorb the vitamin B12 at the GI tract, because it stick with the carrier protein in the food. So after vitamin B12 free from the carrier protein, then it will be bind with the intrinsic factor, then it will go in the terminal ileum, then it will be absorbed. So we are talking again to give enough to repeat this again. Then when serum test we found the vitamin B12 is low, this will give us guarantee that he has deficiency of vitamin B12. Then we have to find out what is causing it. We already know three things cause to have vitamin B12 deficiency: malnutrition, intrinsic factor deficiency, and problem in terminal ileum. So we have to know which one is causing it. Is the food, is the intrinsic factor, or terminal ileum? So most accurate test to diagnose the vitamin B12 deficiency, which cause the pernicious anemia, when vitamin B12 will be low but serum folic acid is normal. After that, what we will do when vitamin B12 will be low, and we will do the test for the intrinsic factor and the antibody against the intrinsic factor, antibody against parietal cell, which are the most accurate to cause for vitamin B12 deficiency. So when both, if any of this is present, we make sure that person has vitamin B12 deficiency because of the lack of intrinsic factor. When we will find this antibody, we don't need anything else to make sure that person has vitamin B12 deficiency. See, for any other reason, only the reason here is he doesn't have intrinsic factor which cause him to problem in absorption of the vitamin B12 in the terminal ileum, which cause the vitamin B12 deficiency. So in Farneser's anemia, we already talked about a lot of time. I will repeat the same thing again. He is breaking down the red blood cell, so his iron will be high, bilirubin will be high, the indirect bilirubin will be high, and his lactate dehydrogenase will be high due to destruction of the red blood cell. If we find person has antibody against intrinsic factor or parietal cell, this person could have gastritis, and when we find this antibody, let's say antibody against intrinsic factor or parietal cell, and we don't need the Schilling test. I'm just repeating again. And when we find that the intrinsic factor against the antibody against intrinsic factor of parietal cell, so we can think that person probably don't have malabsorption or his terminal ileum is intact. And so what is causing again to person have vitamin B12 deficiency? Malabsorption, malnutrition, removal of the terminal ileum, removal of the stomach. If you have a removal of the stomach, because intrinsic factor produced in the stomach, we can get the vitamin B12 deficiency. So when we are going to do the Schilling test, when after we do all of this series, and we will found that there is no antibody present against intrinsic factor or parietal cell, then we will do the Schilling test. So before we do the Schilling test, what we will do, we will do the age test. We will measure the hemoglobin, hematocrit, mean corpuscular volume, neutrophil, and we will measure the CBC. We will look for the lactate dehydrogenase, indirect bilirubin, and the iron level, and the vitamin B12 level, and intrinsic factor, antibody against intrinsic factor, and antibody against parietal cell. And when if we find intrinsic factor, antibody against intrinsic factor parietal cell, and that cause the vitamin B12 deficiency, then this we will call the Farneser's anemia. Person has taking low in the orally vitamin B12, he has vitamin B12 deficiency. In this case, we are not going to tell that this is Farneser's anemia. if an anemia and hypersegmented neutrophil patient has gastritis, so we are talking this again. This person, if we found the person has anemia by know the hemoglobin hematocrit value, we measure the mean corpuscular volume reticulocyte count low, then we do this peripheral test to know the is any presence of hypersegmented neutrophil, and we found it, he has the hypersegmented neutrophil, and we are suspecting he has gastritis due to antibody against intrinsic factor of parietal cell. And so after hypersegmented, we found the hypersegmented neutrophil, we have to do the test for vitamin B12. It is come below normal. Next step, we have to do the test for antibody against intrinsic factor or antiparietal antibody, and this person will have, because parietal cell will be when destroyed due to gastritis, and we will find that he has achlorhydra, his hydrogen level will be, PS will be high, because he is producing less amount of H plus hydrogen. So again, what is the definition of the pernicious anemia? Like say, vitamin B12 deficiency due to malabsorption, malnutrition, GI tract dissection, stomach, or the right hemicolectomy with ileum are not the cause pernicious anemia. When the presence of the antibody against intrinsic factor or parietal cell that cause the vitamin B12 deficiency, then we call it is pernicious anemia. So even suspect patient has pernicious anemia, do the serum B12 test first before know the presence of the antibody at the serum has or not. So I already told all of these, how we'll go step by step. First know hemoglobin hematocrit, then know mean corpuscular volume and reticulocyte, then look for hypersegmented neutrophil, and then look for the vitamin B12 folic acid. Vitamin B12 is low, then you do the test for an antibody against intrinsic factor and parietal cell. If these are present, then we will conclude that he has pernicious anemia. If it be absence, antibody is absent, then we will do the Schilling test. So how we will do the Schilling test? Now we are doing the Schilling test, and first we want to know is diet is causing he has vitamin B12 deficiency. So in Schilling test we want to make sure which one is, because we already talked about three things can give vitamin B12 deficiency: in diet, intrinsic factor deficiency, or malabsorption. What is malabsorption? Because vitamin B12 will be absorbed in the terminal ileum. If terminal ileum in trouble, we will have malabsorption. So first we will give radiolabeled vitamin B12 orally and unlabeled vitamin B12 intramuscularly, and after that we will measure the radiolabeled vitamin B12 in the urine. If urinary radiolabeled vitamin B12 is normal, so this person has a vitamin B12 deficiency, and we give him vitamin B12, radiolabeled vitamin B12 orally, and his radiolabeled vitamin B12 in the urine come normal, we come to the conclusion that this person has dietary deficiency of vitamin B12. He is not taking enough vitamin B12 orally. We give him vitamin B12, radiolabeled vitamin B12 orally, and we found that in the urine his vitamin B12, radiolabeled vitamin B12 is missing. He has low vitamin B, radiolabeled vitamin B12. So when it happened, we are thinking he is taking enough vitamin B12 and he is not able to absorb. So what can happen if we have intrinsic factor deficiency, or he has a terminal ileum, is in trouble. And we found after I give him vitamin B12 deficiency, radiolabeled vitamin B12, his urine vitamin B12 is low. Next time we will give him again radiolabeled vitamin B12 and orally, and also intrinsic factor and unlabeled vitamin B12 intramuscularly. Then again measure the radiolabeled vitamin B12 in the urine. If radioactive vitamin B12 is come normal, then we come to the conclusion that person has intrinsic factor deficiency, which is causing the pernicious anemia. Person could have gastritis. So anytime patient has a gastritis, we have to follow the patient. This person can develop gastric cancer. So how we will follow this patient? We will look at his the stool to see is he have any kind of blood on there. So we have to follow this patient to examine his stool to look for any blood on there or not. So if a patient has vitamin B12 deficiency, we give him vitamin B12 and intrinsic factor. His intrinsic vitamin B12, radiolabeled vitamin B12 is normal in the urine, and we found that he doesn't have malnutrition or malabsorption. But if it be abnormal, we give him vitamin B12, radiolabeled vitamin B12 and intrinsic factor. His urine vitamin B12 is low. Definitely we will come to the conclusion his terminal ileum is in trouble. He doesn't have problem in intrinsic factor problem. He doesn't have malnutrition. And again we will when we give him radiolabeled vitamin B12 and intrinsic factor, but his and after that we do measure his vitamin B12 at the urine, and it is abnormal, and it gives us conclusion that he has intestinal malabsorption. So when it has intestinal malabsorption, we have to look for what is causing it. Crohn's disease can cause it, and damage to the terminal ileum, blind loop syndrome, celiac disease, etc. And if we give the broad spectrum antibiotic therapy, and it can cause overgrowth of the bacteria, or GI tract is infected with the diphyllibulatum. So all of these can cause malabsorption of the vitamin B12. You have a lot of bacteria, diphyllibulatum, it eat up with the vitamin B12. So even the terminal ileum will be normal, but still you have problem to absorb vitamin B12. Or you have a terminal ileum is abnormal due to Crohn's disease, celiac disease, and you can have problem to absorb the vitamin B12. And this person doesn't have malnutrition, he doesn't have no intrinsic factor deficiency. Then another thing, you are suspecting the person has anemia, and you do the hemoglobin hematocrit test, you do the mean corpuscular volume and the reticulocyte, and you found he has macrocytic anemia, reticulocyte is low, and you found his peripheral hypersegmented neutrophil, and you do the test. After you next test, you do the serum level of vitamin B12, and it come normal, but you are suspecting he has anemia, and you're suspecting it could be vitamin B12, and probably he also have a neurological symptom. So what is the next test you can do to make sure he has vitamin B12 deficiency? Even his serum vitamin B12 is normal. Next thing, you have to do the test for methyl malonic acid and homocysteine. Measure the serum methyl malonic acid and homocysteine, and both will be increased. Even his vitamin B12 is normal in the serum, but he has a vitamin B12 deficiency. His methyl malonic acid and homocysteine, and both will be increased. If someone has a folic acid deficiency, only his homocysteine will increase. So methyl malonic acid is more specific to vitamin B12 deficiency. So vitamin B12 deficiency, person serum vitamin B12 is normal, but we have all the symptom. Lab test has give us hints that it has vitamin B12 deficiency, and next test we will do the methyl malonic acid and homocysteine. If both increase, we are make sure that he has vitamin B12 deficiency. Only homocysteine increase, he has folic acid deficiency. So again, if we do the bone marrow biopsy, what we will see? Marrow is hypercellular, even red blood cell count is decreased. Why? Because his red blood cell is breaking down at the bone marrow or in the peripheral. So what we can, how we will deal this guy who has a vitamin B12 deficiency? We can give him vitamin B12 orally or intramuscularly. If he has vitamin B12 deficiency due to the malnutrition, if he has intrinsic factor deficiency, and we will give him vitamin B12 intramuscularly. If you have terminal ileum deficiency, it has a problem, we will give him vitamin B12 intramuscularly. If you have the nutrition problem, we can give him orally or even intramuscularly. But other two cases, we have to give him vitamin B12 intramuscularly. So look at some note. We are talking about all of this, about the vitamin B12 deficiency, what could happen, and what lab test we have to do. Now just give little note about this, some short note. If a person has vitamin B12 deficiency for short time and he just shows minor neurological problem, by this time, and you found he has like this peripheral neuropathy, is still in minor, and if you, in this case, in very early stage, if you intervene and if you give him vitamin B12, his neurological condition will be improved. What about, like, say, both folic acid deficiency, vitamin B12 deficiency, all give the megaloblastic anemia. Folic acid doesn't give neurological problem, but person has vitamin B12 deficiency and he has the red blood cell problem, blood problem, also neurological problem, but you give him folic acid, what could happen? His blood problem will be solved, but neurological problem will not be solved. So we have to give him warning. If this patient has vitamin B12 deficiency and we give him folic acid, it will improve the anemia. But folic acid could make the neurological condition worse. So after we know that patient has macrocytic anemia and he has hypersegmented neutrophil, we are thinking he has a megaloblastic anemia due to vitamin B12 deficiency or folic acid deficiency, and if person has vitamin B12 deficiency, we have to give him vitamin B12 first. After then we can give him folic acid. So again, what is pernicious anemia? A lot of people ask, is a tricky question. What is pernicious anemia? Pernicious anemia is when there is a presence of anti-intrinsic factor, anti-parietal cell antibody, and that can cause the vitamin B12 deficiency. Then we will call it pernicious anemia. And if these two antibody is not present, but he has a vitamin B12 deficiency due to malnutrition or terminal ileum is not functioning properly, because malnutrition, malabsorption, we would not call it pernicious anemia. And we talk about if someone has pernicious anemia, the person could have gastric carcinoma, and the person can develop gastric carcinoma compared to the people who doesn't has gastritis due to antibody against intrinsic factor, anti-parietal cell. So we have to follow this patient. How we will do it? We would have to periodically we have to test the stool for the blood. So we already know that Crohn's disease, celiac disease, all can screw up the terminal ileum, and this can cause the GI tract abnormal and cause the malabsorption, and it can also cause malabsorption of the iron, vitamin B12, folic acid deficiency. So when patient have celiac disease, Crohn's disease, this can also cause iron deficiency and vitamin B12 deficiency and folic acid deficiency. So when iron deficiency happen, patient has microcytic. When has vitamin B12 and folic acid deficiency, he can have macrocytic. So person can develop macrocytic and microcytic anemia. Let's just go overall everything again to give you little idea what's going on here. And if someone know until this point about the vitamin B12 deficiency, I think that will be fine, but I'm just going to repeat everything again. Intrinsic factor is produced in the stomach by the parietal cell. If patient's stomach is taken away, like gastric resection, or patient has autoimmune disease, cause atrophic gastritis, which destroy the stomach mucosa, then patient has intrinsic factor deficiency, and intrinsic factor is produced in the stomach mucosa. We know this, right? So intrinsic factor is essential for the absorption of the vitamin B12. So antibody is producing against intrinsic factor, parietal cells, and intrinsic factor will be in trouble. We will not have enough intrinsic factor. Without intrinsic factor, we cannot absorb the vitamin B12. Autoimmune antiparietal cell antibody, anti-intrinsic factor antibody will lead to react against the parietal cell in gastric mucosa, and patient develop gastritis and destroy the parietal cell. Parietal cell is the organ where intrinsic factor will be produced, and also parietal cell produce the hydrochloric acid. So intrinsic factor is essential to absorb the vitamin B12 in the terminal ileum. So without intrinsic factor, patient could have vitamin B12 deficiency. Chronic gastritis causes achlorhydria, lack of hydrochloric acid. Patient has anti-intrinsic factor, anti-parietal cell antibody due to autoimmune disorder. Again, we have to do this again. This is the more important about the pernicious anemia. So parietal cell produce in the intrinsic factor and hydrochloric acid. Gastritis patient is more prone to develop the gastric cancer, and we need to follow this patient by frequently we do the stool test for blood. Malabsorption occur in the GI tract cause vitamin B12 deficiency. GI tract infection with the tapeworm like Diphyllobotrium is a kind of bacteria overgrow the use of broad spectrum antibiotic therapy. So this also can cause the vitamin B12 deficiency because it taking the vitamin B12 and left little bit of the host. Patient has blind loop syndrome where bacteria overgrow and cause the deficiency of vitamin B12. So someone has overweight and he did the gastrectomy, he make his stomach small and he will develop the blind loop syndrome where bacteria will grow and it will eat the vitamin B12. Patient has intestinal malabsorption syndrome like celiac disease, SPOOR, or patient has distal ileum is dissected. Distal ileum is the place where vitamin B12 intrinsic factor is absorbed. Bacteria use vitamin B12 if patient has blind loop syndrome. So human being cannot use the vitamin B12 and he can has vitamin B12 deficiency. Clinical presentation of vitamin B12 deficiency is variable. He can have anemia, he can have neurological problem, or he can have both. Clinical presentation of pernicious anemia is like other anemia. So all anemia show the same symptoms. So you don't use it to come to the conclusion of what is causing the anemia. Pernicious anemia caused by vitamin B12 deficiency. Vitamin B12 deficiency caused by the anti-intrinsic factor antibody or antiparietal antibody or malabsorption, malnutrition, part of the GI tract dissected, etc. These are the etiology of the cause of the vitamin B12 deficiency. So when malabsorption and malnutrition cause the vitamin B12 deficiency, we don't call it pernicious anemia. Patient could have all these symptoms, but I could give vitamin intramuscularly to prevent the pernicious anemia. If patient has malnutrition cause it, we give him vitamin B12 orally, or severe case intramuscularly. But he has intrinsic factor deficiency and malabsorption, his terminal ileum is screwed up. We can give him vitamin B12 intramuscularly. Very important to know this. Vitamin B12 deficiency. Vitamin B12 is stored in the body and also found in the serum. When body store of the vitamin B12 go down, serum methylmalonic acid will go high. So even serum vitamin B12 is normal, does not rule out that the patient does not have the vitamin B12 deficiency. When methylmalonic acid go up, then it indicates that patient has vitamin B12 deficiency. So again, what is blind loop syndrome? When an overweight person do the bypass surgery to lose weight or do the gastrectomy for any other reason, there could have overgrowth of the bacteria at the bypass loop. The overgrowth bacteria eat all the folic acid and vitamin B12. So we call it blind loop syndrome. And vitamin B12 deficiency cause the problem erythroid precursor in the bone marrow to die. So without vitamin B12, erythroid precursor in the bone marrow will die and patient will develop megaloblastic anemia called ineffective erythropoiesis. So again, come to the neurological thing, variable neurological symptom. Vitamin B12 can give variable neurological symptom. Patient could show all the neurological problem, or he can show one or two neurological problem. Any level of neurological problem could be seen. Anything you can see when patient has vitamin B12 deficiency. So clinical presentation is not fixed on here. Some patient may show only anemic symptom, some patient may show only neurological symptom, or some patient may show both neurological and hematological symptom. And it can show the symptoms of sympathetic nervous system, parasympathetic nervous system problem. What is the other cause of macrocytic anemia? If patient has liver disease, if patient has hemolytic disease, like he's breaking down the red blood cells, so in this case his reticulocyte will be high. This reticulocyte will give the his mean corpuscular volume will be greater than 100. And if patient has myelodysplasia, so in vitamin B12 deficiency, it gives the oval macrocyte, but this case, liver disease, hemolytic disease, myelodysplasia, it will give the red blood cell round. So this is also distinct between deficiency of the vitamin B12 and the macrocytic anemia due to liver disease, hemolytic disease, myelodysplasia. When a patient has low serum vitamin B12 and also presence of anti-intrinsic factor antibody, patient autoimmune disease which causes the gastritis and destroys the intrinsic factor, patient may also have antiparietal cell antibody. And gastric mucosa destroy. In this case, we will do the endoscopy to look for the stomach. When antibody is present in the serum test, and we already talked that he doesn't need the Schilling test. So when we will find the person has the antibody against intrinsic factor and parietal cell, we were thinking he has a gastritis, and we can look at the do the endoscopy to look at his stomach. And when there is no intrinsic and antibody against intrinsic factor and no antibody against parietal cell, we can do the Schilling test. So what vitamin B12 deficiency can cause? Pernicious anemia. It can cause the demyelination of the posterior and lateral column of the spinal cord. So it can cause subacute combined degeneration of the spinal cord. Vitamin B12 deficiency can cause the subacute combined degeneration of the spinal cord, and patient will show the symptom of the deficit of the posterior and lateral column, and again folic acid deficiency will not show the neurological problem. So when we will make the conclusion that he has a hypersegmented neutrophil, normal neutrophil has less than 4 lobes, but if 5% of the neutrophil has greater than 5 lobes, or any single neutrophil we have 6 lobes, then we consider that person has hypersegmented neutrophil and he has megaloblastic anemia. So again, if a person has antibody against intrinsic factor, antibody against parietal cell, and he looked normal, he doesn't show the symptom of vitamin B12, and we know that normal people, if he don't take any kind of vitamin B12 for 5 years, after that he will show the symptom of vitamin B12 deficiency, not before that. But if a person has antibody against intrinsic factor or parietal cell, and he suddenly develop the problem in the terminal ileum, or he is stopped taking vitamin B12, he can probably, before the 5 years, he can develop, even very within short period of time, he can show the symptom of the vitamin B12 deficiency. So we know what vitamin B12 do in DNA synthesis. It need to synthesize the vitamin, the DNA. So vitamin B12 deficiency can impair the DNA synthesis. Without vitamin B12, there is a problem to make the purine molecule for the DNA synthesis. So without the vitamin B12, there will be problem in the DNA synthesis, and red blood cell will be high, and bone marrow will be shown that he has hypercellular in the bone marrow, and this red blood cell will be break down easily, and he can show his iron in the serum will be high. He could develop indirect bilirubin could be increased, and and his lactate, because he is breaking down the red blood cell, his lactate dehydrogenase also could be increased. So this is the end of the USMLE Step 2 CK Hematology Part 8. I talk about the vitamin B12 deficiency. I try to give very explanatory type of lecture about the USMLE, and hope this material, if you understand and if you know this material, you will able to do very well in USMLE Step 2 CK. I'm not giving the high yield material, I'm giving the everything you need to know and understand. That's why I'm trying to repeat everything again and again sometime to make you understand, and you can retain this material in your brain, and it will be easy for you to memorize all of this if I repeat again and again. And you will probably see my book in USMLEgold.com, and probably the lecture will be more than 300 hours. All right, our next topics will be folic acid and hemolytic anemia, normocytic anemia.